Our next speaker is the president of the American Association of Hip and Knee Surgeons and chair of the Department of Surgery at the University of Arkansas, Lowry Barnes. Dr. Barnes, we all want to get back to work, but after we know ourselves and after listening to Dr. Zuckerman, it's not as easy as flipping a switch, both in terms of your own institution, but also more broadly for all hip and knee surgeons. What are some of the considerations for getting back to performing orthopedic surgery? Lowry.
Right. Thanks, Robin. And Joe, just as you said, healthcare is local. And so I think it's important to understand the practice and environment in which I practice. Our state of Arkansas has about 3.1 million population. We've only tested 45,000 of our population. 7% are positive, so just over 3,000 Arkansas residents positive for COVID. Of those 3,000, about 1,000 of them are inmates. So about 2,000 community positives. Our university is taking care of our share of the state's COVID needs, and certainly have been in the ramp-up phase, getting ready for the peak. Our peak was initially predicted to be earlier this week, and we've had initial projections were that we would have 2,000 patients hospitalized in our state at that time. We average about 100 patients per day being hospitalized now. And the newer data suggests that our peak may still be 8 or 9 days away, but that is based upon these 1,000 tested positive and how so it may not pan out because we look at raw numbers. Nobody looking at the data knows from where these positive tests are coming. Our governor did share 2 weeks ago that we could begin elective surgery on April 27 in our state. Our institution has decided not to move that quickly. So I happen to be in charge of our return to the operating room. The head of general surgery and I are handling that. And we've decided to start back on May 11. That gives us time to get things ready. As Joe mentioned, there's a lot of things you have to do to get your institution ready. You have to make sure that your employees are back doing what they normally do to help take care of things. And then you have to look to see, do your current facilities work to make sure that you can go back at full strength? Well, and oftentimes they don't. You're going to have to make modifications. We know that CMS has recommended that you have geographical barriers or setting up an NCC or a non-COVID care area separate from the COVID care area. So for us, we have a little over 1,300 cases that have been delayed because of COVID, and about 600 of these are orthopedics. Our department does about 8,000 cases a year. Many of these patients, unlike Joe, where you have a small percentage or 30% of your patients are hesitant to have surgery because, I think it's because of where you practice and that New York is the center. As part of a national study that ACUS did, we surveyed 52 of my patients who are scheduled for hip and knee replacement, and all 52 are anxious to get back on the schedule. So it's because our burden has been low, although we have a lot of press and a lot of concern. Most people in our state feel comfortable that when the university goes back to work, it's safe. So we'll see how that pans out. As we move towards surgery, though, on May 11, to give you an example of our challenges, we have 8 operating rooms in our outpatient area, which is separate from our main operating room in a different building, et cetera. So it's easy to have that as a non-COVID area. The challenge is, like many outpatient areas, the pre-op area and the PACU are not established for that kind of volume to have enough patient separation. So we will not open all 8 rooms. We will use only 4 of our operating rooms because we can only handle about 6 patients at a time in the pre-op area if we're going to have appropriate social distancing. So we're using half of our pre-op bays as well. And we'll start back only doing ASA 1 and ASA 2 patients. All patients will be a regional or spinal anesthetic, no general anesthetics for the first 2 weeks. We'll start back only doing 5 cases per room per day. The second week, we'll go to 6 cases per room per day. Certainly significantly below our norm, but appropriate because of the concerns to make sure that how we bring patients in. We will not be using waiting rooms, so our patients will will have their cell phone number, and when it's their turn to come to the pre-op area, they will call and they'll come to the door, and valet will meet them, and they'll be escorted to the pre-op area, because it's the days of using waiting rooms for a while are over at our institution. We'll have no visitors with the patients for their surgery, so they'll have to wait, and we'll call them to when the patient's ready to be discharged. No overnight stays for the first few weeks, at least, and no general anesthetics. Some of the guidelines our state is using, that all elective cases have to have a negative COVID test within 48 hours of their operation. That is a major challenge, as you might imagine. So many of the institutions who have opened for elective surgery already are doing very small volumes because they can't get the testing done. We're at somewhat of an advantage there because we do have in-house testing, but we don't have a whole lot of capacity because we started drive-through triage early, and it's been very busy, and so we're doing a lot of testing through that. And of course, we're testing our workers, healthcare workers who are exposed to COVID patients and those who develop symptoms. So the testing beforehand within 48 hours can be a challenge. We'll certainly ask that our patients try to be quarantined as much as they can before their surgery as well. In addition, in the second and third week, we'll open up 2 rooms in our main operating room. These will also be for outpatient surgery, but we'll also be doing some general anesthetics there as well. Although all of our patients will be tested within 48 hours, our anesthesia team currently is treating all patients as if they are COVID positive because of the concern about false negatives. Therefore, that means a 15 to 20 minute delay in the beginning of the operation, and a delay at the end of operation during intubation and extubation. So we know we will certainly not be as efficient then, and not all of our operating rooms will be used. We've been running about 4 ORs a day now, taking care of urgent needs. We are a level 1 trauma center, so we have been busy, and interestingly enough, that during the period of time when we're supposed to be social distancing, most businesses are closed, and people are at home. We've had a significant level of orthopedic trauma, and especially our hand injuries. It's amazing how many chainsaw injuries and injuries to the hand from people doing projects at home. So we've stayed busy. We hope to open 4 more operating rooms in a graduated fashion over the next 3 to 4 weeks. And again, just like every institution, we'll be watching the numbers, not just the state numbers, but the numbers that are in-house. So of our hospital number of patients being treated for COVID, requiring hospitalization, begin going up, our ramp-up phase will stall, and we'll wait to make sure that we're appropriate in doing so. Our patients, as far as how we'll work it during the day, our patients for testing will use our drive-through triage system. It's a 7-day-a-week triage seeing who should be tested. These patients will come in with an order for testing. They can also have blood drawn while they're in their car as well if they need any labs prior to their surgery. And then we'll update their history and physical the day of surgery. We'll try to discharge patients quickly. Most of our total joints here have gone home the following day. We've been doing it that way for a number of years. Now we'll go ahead and start sending these patients home the day of. And so when we look at who has their surgery first, it'll be those patients who think they have enough support to go home the day of surgery. And we'll do those. We do most of our total joints here under general, and we'll change for this, and we'll do them under spinal for these cases. After discharge, we'll be doing telemedicine visits. for as much as we can. We've been doing that now, and have found it to be something that patients really like. The information I heard one day last week is there's some data that shows if you spend 5 minutes with a patient in your office, they're convinced that you spent less than 5 minutes. But if you spend 5 minutes with a patient on telemedicine, they're convinced that they spent more time with you than that. So it is a very much an interactive visit where they feel engaged. And, he asked, one of the questions I want to address is, what's our institution doing on a day-to-day basis to keep up with the data? We have what we call the EOC room, the Emergency Operational Control Center, and we meet at 7:45 and 4 p.m. every day, with leadership by Zoom, to go over the state data as well as the hospital data and address issues of concern. It's very much like a war room type approach. So I think that at our institution, unfortunately, you ask about total joints in particular, they will actually be one of the last to go back to work. And that is because our laminar flow rooms are the safest place for us to do COVID patients currently. So they are part of the 4-room block of rooms that are the COVID treatment rooms in our operating room. And so we're on delay a little bit longer. So, but it's, it's been an interesting time at our hospital. You really see who the leaders are and who are the ones who are going to be engaged to help make decisions. And you see those that have teams that are ready to go forward and move in an appropriate fashion. So you learn a lot about your institution, a lot about your leadership. And again, we are very fortunate at this stage that we have a very low prevalence of disease, but we're still taking precautions, just like we had hit the projections that we thought we were going to hit. So thank you very much.
Thank you, Lowry.